perfect. So we're going to talk a little bit about hips now. And I'm going to go through a debate that I did with my boss. So at HSS, the former person who had my role, his name was Doug Paget. He's now Surgeon-in-Chief for the whole hospital. So although he was involved in the development of the Mako robot for hip replacement, he doesn't use it, and we had to debate recently. So this is some of that debate. So this is Doug Paget. If we look at what it says on his jacket there, he's now Surgeon-in-Chief, not Associate Surgeon-in-Chief. What does that really mean? It means he's my boss, and I had to debate him on this topic. So Doug Paget was actually involved in the development of the Mako robot. He was involved in it right from the start. So this actually started, the company actually started in somebody's basement in Florida. And the company was originally called ZCAT. The company went from ZCAT to being called Mako, and then was bought by Stryker over a decade ago now. So if we also look at Doug Paget, he's got some patents on all of the Mako stuff. So he was debating me, but I think I had a couple of things on him. And then a couple of papers that he wrote: Robotic Guidance in Hip Replacement, The Shape of Things to Come. Surgeons want to perform a perfect hip arthroplasty with every operation. Human performance has limitations, especially when performing a mechanical operation in a biological environment. So the argument against using a robot for hip replacement is that hip replacements do really well, right? So I don't need it because hip replacements do well without it. So the question is, why do I think in 2025 that it can be so helpful? So what are the advantages today? So similar to the knee, I get a CT scan beforehand. From that CT scan, I know my three-dimensional templating for sizes. It means that we need a lot less inventory around if I know my sizes before we get into the operating room. We can do impingement modeling now. So on the computer, you'll see in a minute, I can actually take the hip through a range of motion, and I can see as I adjust my implants, where are things going to be impinging. I can make adjustments to that to avoid that impingement. And then it's a very fast and simple operation with the robot. It's a single reamer that's haptically controlled, so very easy to ream. You put the implant in, and it's perfect every time. So our 3D planning, for two-dimensional planning, we plan on an AP image, right? So we really plan our acetabular components from top to bottom. If you look at this, we're now planning from front to back. So we're seeing that AP dimension of what size acetabular component is going to fit in there. On the side of the screen here, you can see that's a 52 millimeter acetabular component that's going to go in here, but you can see in both planes what size acetabular component we're going to use. And then we can do the same thing on the femoral side. Then we take the hip through a range of motion. So this is an extension and external rotation. So I can see where we're getting impingement. So you can see I'm not getting any impingement. You'd see this in red if we had impingement on the implants. I'm actually getting impingement on the lesser trochanter, on the ischium down here. The only way to adjust that is either by increasing offset or changing version of the femur. And then up here in flexion and internal rotation, you can see that I'm starting to get impingement of the femoral neck on the acetabular liner, but not until 65 degrees of internal rotation. So lots of internal rotation before we get to impingement. So I can adjust my implant positions, and you can see here, I've set this acetabular component at 43 degrees of inclination and 19 degrees of aneversion to optimize the impingement modeling there. So if we look at reaming, the reamer goes in, and all I do is I pull the trigger on the reamer and start pushing, and I'm looking on the screen up here behind you as that green, so I'll play that one more time. So you've got the green bone up here, and as I hit the reamer, that green bone is going to start to disappear, and because it's haptically controlled, it won't let me ream any more than that. So it's a single reamer I'm not reaming, taking the reamer out, looking to see if I'm deep enough. Nope, not deep enough yet. Put that reamer back in, do it again. Okay, now I'm deep enough, but I've got a small size reamer. Now I'm going to go up by 2 millimeter increments. I've got one reamer and I know exactly what I'm going to ream. That reaming took 17 seconds. So then to put the implant in, same thing. I've got the actual component on the end of the insertion handle here. I ask my rep over here to lock in the position of the implant. That actually pulls the implant into the exact alignment that we wanted, and then I just impact the implant. So again, very simple to do it. So we looked at our place at complications after 2,888 hip replacements. This was 4 surgeons. So this was myself, Seth Jarovic, Peter Skulko, and John Vigdorchak. And they were all done through a posterior approach or some version of a posterior approach. I now do a piriformis sparing posterior approach, which we can talk about surgical approaches in a couple of minutes if people want to. 4 surgeons. We do sitting and standing lateral x-rays. We use a machine called EOS, but as long as you're getting lateral sitting and standing x-rays, you can see what's happening with the spine and the pelvic position from sitting to standing. That very much helps with impingement. We'll talk a little bit more about that during the meeting on Saturday. And what did we find? We found that we had very good results. So our risk of dislocation, right? Remember, the people that argue against the posterior approach argue against it because of a high rate of dislocation. It's the only reason that people argue against posterior approach. So our rate of dislocation was 0.35% using this system. And if we got rid of people that had instrumented spine fusions, that dislocation rate went down to 1 in 1,000. So, 1 in 1,000, I don't think you're going to get rid of 1 in 1,000. That's somebody that falls down the stairs, they fall out of bed, something happens. Our infection rate was 0.2%, which is the same as the overall infection rate for hip replacements at HSS. Basically, what that was showing is some people were concerned that having the extra equipment, the extra instruments in the operating room, the extra people might increase our infection rate. Our infection rate was no different than anybody else, than the overall infection rate for hip replacement at HSS. And we found that our #1 complication now was periprosthetic femur fractures at about 0.52%. And if you look in the literature at the risk of periprosthetic femur fracture with uncemented femoral stems, the reported rates are anywhere between 0.5% and 1%. So we were right in line with everybody else. After we did this study, we all converted to 2 different collared triple taper femoral stems, which I understand are pretty brand new here in India, but now available. You'll be able to see them at the booths outside. Stryker has an implant called Insignia, which is now available here in India, which is a triple taper collared stem. We looked at our subsequent 3,000 hip replacements, and that periprosthetic fracture rate went down to 0.1%. So a very significant decrease in fracture rates. And with that, we didn't see any other increased complications. We didn't see thigh pain. We didn't see loosening of the implants. One of the fastest moving trends in the United States right now for femoral stems are these triple taper collared femoral stems, which I actually, when they first came out, I thought that this wasn't a good idea. I said to myself, if you're putting an uncemented stem in, the goal is to get a tight metaphyseal fit for bony ingrowth. So if you put a collar on, one of 2 things is going to happen. Either the collar is going to hit the calcar and you're not going to know that you've got a tight metaphyseal fit, or you're going to get a tight metaphyseal fit and that collar is going to sit proud. So then why do you even have a collar? So I was not a big proponent of this type of stem when they first came to market. But the fact is, they've significantly decreased our #1 complication in uncemented total hip arthroplasty, and we haven't seen any loosening or any thigh pain. They've been a wonderful addition to what we've done. So the other thing that we did is we looked at our fellows. So people that had never used Mako for hip replacement before, because one of the concerns was, is this going to add more time to my surgery? right? I don't want to bring all this extra stuff into the operating room. It's going to add time to the surgery. I don't have time. I've got to get through my day. So we took 6 of our fellows in 2023. We recorded 61 cases. And what we looked at was, were the cases overall longer or shorter? Where did it take extra time? Where did we save time? And what was their learning curve? So on average, it took just under 3 minutes to put the pins and arrays on, and just over 3 minutes to do the registration. And then we saved time on their reaming. So in an experienced surgeon's hand, so when I do that now, it takes about 1 minute to put the array on and under 2 minutes to do the registration. So you can say it adds 3 minutes, but you saw it took 17 seconds to ream. So you save a significant amount of time on the reaming. So I would argue that in 2025, the argument shouldn't be, why would you use a robot? It should be, why not use a robot? It's better for supply chain, right? For the companies, it's easier. You know, I know one of the issues here in India sometimes can be, do we have all of the things that we need? Is everything in my hospital when I need it? If you've got this CT scan beforehand, you know exactly what you need before you get into the operating room. So it helps with supply chain management. You're able to do the 3D impingement modeling that I showed you before. There's really minimal additional OR time, and I would argue that after about 10 cases, your hip replacements will be faster than what you did beforehand. Number one, because the reaming is so quick, and number two, because there's no guesswork. You're not putting an acetabular component partway in, looking at it, saying, oh yeah, that looks pretty good. You put it in a little further, you say, oh, you know what, maybe I wanted a little more antiversion on that. You take it out, you reposition, you start over again. So there's none of that. So you actually save time in the operating room. It's incredibly precise. There's a minimal learning curve, and we can see that there's a very low complication rate. So I would argue in 2025, why not use a robot rather than why use a robot? I think it just makes you a better surgeon, and we all want to be better surgeons. So I'll leave hip there. We've got some time for questions.
Yeah, so 1 or 2 questions because we're running out of time. So anybody has any questions? Yes. So while he comes up, I just have one, philosophical question. What do you see in 5 years' time? Let's say we have this ROC meeting. Do you think that there will be more robot users, or will there be something new, technology coming up? What is your prediction in 2029?
Yeah, so we've seen the utilization of robotics in knee replacement take off much faster than the use of robotics in hip replacement. I'll tell you, the fellows that leave HSS, they all want to use it for hip replacement, and some of them want to use it for knee replacement. So when people actually see both hip replacement and knee replacement, people are sold more on hip replacement than they are generally on knee replacement. A lot of people think, well, I can do knee replacements pretty well. We're arguing about 1 degree or 2 degrees, but does that really matter? We've shown with this on hip replacements that we can lower the risk of dislocation, and that we're just much more precise in an operation that we're not very precise without it. So I think it'll actually become much more popular. There is other technology coming. There's a lot of either augmented reality or virtual reality headsets that are coming to the market. I think people will start using some of those as well. But I think this is going to become significantly more popular over the next 5 years.
Great. So we'll take 2 questions first behind. Yeah.
So sir, you compared the fellows timing also. Do you have express and enhanced workflow in US also, or you do only enhanced workflow in the US?
That's right. So what he's asking is there are 2 different workflows with the hip. The workflow that I showed is called the express workflow, which is the impingement modeling, the acetabular component position, and then you take a checkpoint on the femur to measure leg length and offset. There is an enhanced workflow as well, where you put a secondary array on the femur, and then it can actually show you the position of the femoral stem that you're putting in while you're putting that femoral stem in. The large majority of people using this system today are using the express workflow, because the femur just goes where the femur goes, right? If you're using an uncemented hip replacement, you've got very little ability to actually change version, especially with some of these newer triple taper colored stems that are actually much bigger in the metaphyseal region. And using the checkpoint has been quite good for leg length, The question mark we're still trying to improve is offset measurements.
Thank you, sir.
Yeah, last question.
So you told about the collared stems. So the accurate stems like the tapered stem are doing pretty well. Then why the collar?
So it's lowered fracture rates. If I had to give you one reason, I would say it's lowered fracture rates without any other complications. And I was not a quick adopter of the technology. I didn't think that adding the collar would do what it's done. But if we look at the American registry now, it's taken off, and there's paper after paper after paper showing lower fracture rates without any additional complications.
Same for the cemented version also, or only for the uncemented
It's
version?
for uncemented. And what it's done for us, so because we saw a higher periprosthetic fracture rate, we actually started increasing the number of cemented stems that we were doing. So we went from a practice that was probably 98% uncemented femurs. We saw an increase in our periprosthetic fracture rates. So we went to probably 90% uncemented and 10% cemented. And now with the addition of the collar, we've gone to almost 100% uncemented, probably 99%.
The recommended collar for cemented one also?
So that's a whole other debate based on the shape and the surface finish of an uncemented or of a cemented stem. So if you look at polished cemented stems, which have polished, tapered, cemented, uncollared cemented stems, they have very, very good long-term results, but those ones can still fracture. The cemented stems with collars have the lower fracture rates. So it depends what you're trying to get. If you're trying to cement a 60-year-old active person and you're not worried about fracture, you're probably better with a tapered, non-collared, polished stem. And if you're putting it in somebody with a femoral neck fracture with osteoporosis, you're probably better with a collared cemented stem.